Hi everyone, Dr. Mike here. Now you're probably watching this video because you want to know why in some types of heart attacks there is an ST elevation on the ECG and in other types of heart attacks there's an ST depression. Now it's quite complex, but I think we can get through it pretty easily and pretty quickly. So let's take a look. All right. All right, to begin, we need to just do a little bit of a background so that we're all on the same page. We need to understand the ECG. So we know that there's these sticky dots that we put on our chest called the precordial leads, and those that we put on our limbs called the limb leads, and they give us 12 separate views of the heart, which we call the 12 leads. Now, I've drawn up two hearts here because I need to show you what's happening in ST elevation and ST depression. But first, I want to talk to you about what happens in a normal heart that a heart attack is not happening in. So, we've got a lead that actually looks at the heart from this direction, right? I'm going to draw it on both of the hearts. So this lead is looking at the heart like this, from this angle up. And what it's doing is it's picking up what's happening either towards it or away from it electrically. That's important. This is what we call lead 2. Now, if I am lead 2, all I'm detecting, again, is what's happening towards or away from me electrically. So we've got the heart here, and let's say we have, and you probably already know this, but again, it's good to recap because we need to for understanding what's happening in ST elevation depression. We've got the SA node here, we've got a fibrous bit of tissue here, that's important, and the AV node here. Now the SA node spontaneously depolarizes, so it sends its electrical signal through the myocardium, the heart muscle of the atria, in that direction. That's important because when we do an ECG, first of all, we've got our baseline, right? Nothing's happening. So we've got nothing happening, and then the SA node spontaneously depolarizes, and the depolarization event occurs in that direction. Now that direction is happening in the direction of the lead. And there's a cheat sheet, right? If you have depolarization happening in the direction of the lead, which is happening here, right? In the direction of the lead, you get a bump up on your ECG trace. So when the atria depolarize, we get a bump up on the ECG trace, which we call the P wave. Then, because of this fibrous tissue, the electrical signal can't move through it. So the electrical signal must funnel through the AV node, and that's why we have a little bit of a break here. Then, when it funnels through the AV node, it gets sent through the bundle branches, which go through the septum, the interventricular septum. And they've got little offshoots like that. Now, as you can see, that's where the depolarization event moves through. Most of it is happening in these short, sharp fibers here of the bundle branches away from the lead. So we get a short, sharp depression. Now you might be thinking, why depression? Because when we have depolarization happening away from the lead, which is happening here, away from the lead, we get a dip down or a depression on the ECG trace. So that's why we've got that depression there. That's indicating, that's called the Q wave, the interventricular septum depolarizing. Then it moves through the Purkinje fibers, right? So here are the Purkinje fibers. They send the electrical signal through the bulk of the myocardium of the ventricles, and they go and depolarize in that fashion. Now you might be thinking, some are going towards the lead like these ones, some are going away. Remember, the left ventricular wall, 3 times thicker than the right. So whatever's happening on this side electrically, that's important. It's going to overwhelm whatever's happening here. So that means, in this instance, it's happening in the direction of the lead. Thick tissue, a lot of conduction happening here, so we get a really big bump up on the ECG trace. That's called our R wave. And then we have the final depolarization happening at the very end of the myocardium. That's happening away from the lead, so we get our final dip down. It's called the S wave, and then it's all depolarized. It's all depolarized, right? So we have a bit of a break, and then we reset the heart, called repolarization. And that repolarization gives us our final wave, which is our T wave. And then the whole thing begins again. So now that we know this, we can have a look and go, okay, in some types of heart attacks, this ST segment is elevated, and in others, it's depressed. Why? All right, let's have a look on this side of the heart. So firstly, a heart attack, also known as a myocardial infarction, this is when the heart muscle itself, particularly the ventricles, are not getting the oxygen and nutrients that it requires to be fed and to survive. Now, importantly, we need to understand how the blood vessels feed this heart muscle tissue in order to understand what's going on. So if you've got your heart here, right? And we're not going to cut into it like we have here. We're going to have the aorta coming out, and we know we've got the left coronary artery and the right coronary artery exiting at the base of the aorta. The left coronary artery, we know, can feed this left ventricular wall all the way to the apex and even the interventricular septum. And this is what we call the LAD, the left anterior descending coronary artery. Now, importantly, I'm focusing on this one. A blockage can happen in any of the arteries, resulting in a heart attack. This is an important one because if it gets blocked, let's say here, if the blood vessel gets blocked, or the tissue distal to the blockage, so away from it, that tissue doesn't, the underlying tissue doesn't get fed, right? So if we have a look at the blood vessel, see how it's actually lining the surface of the heart? So there's the blood vessel there, right? Let's say that's the blood vessel and we're looking into it. It's going to be partially embedded in the epicardium. So you've got the epicardium here. Then you've got the myocardium, that's the muscle itself, the contractile portion, and the endocardium, which is the inside of the heart. So epi, myo, endo. And this is important to understand because when that blood feeds this tissue and diffuses oxygen and nutrients, it's going to feed the epi first, then the myo, then the endo. So if you have a blockage in this vessel, right, you've got a blockage, which will be, so the little oxygen and nutrients available will basically all go to the epi and then whatever's remaining to the myo and then nothing to the endo. So when you have a heart attack, the first tissue to die off is the endocardium, the inside portion. And so it's progressive, right? This dies off first before the rest dies off because remember the blood vessel is here on the surface. So of course the oxygen and nutrients is going to get to the epi before it gets down to the endo. So hopefully that concept makes sense because we need to talk about two types of heart attacks. One which we call a subendocardial infarct, that's this one here. And then another one which goes the full width of the tissue, which we call transmural. So this one has just died off, the whole tissue has died off the full width of the heart muscle. So we need to understand that first of all. All right, next thing we need to take a look at here is what's going on with the ECG, elevation and depression. All right, in this instance, think about this. We know that in order to understand the electrical activity, to do this, we know that there has to be what we call a resting membrane potential. There's a charge difference from the inside to the outside. So we know that we've got something called a sodium-potassium ATPase pump. The job of the sodium-potassium ATPase pump is to throw 2 potassium inside and to exchange that with 3 sodium outside. Now have a look at that. 3 positive things have been thrown outside, 2 positive things have been thrown inside. So the outside starts to get a little bit more positive compared to the inside. But we also have some channels, some potassium channels that are a little bit leaky, right? So the lid's open a little bit and the potassium can leak out a little bit, carrying the positive charge with it, making the outside even more positive compared to the inside. Now, this charge difference is what we call the resting membrane potential. When we depolarize heart muscle, we throw positive things in to make the inside positive. So to depolarize a heart muscle, the inside must become positive. Keep that in mind. Right, so what's going on? In this subendocardial infarct, these cells are dying off, right? They're dying off or they're not getting fed enough oxygen. And when this happens, they spill their guts. They leak potassium out because some of the channels that keep the potassium in are ATP dependent, right? And if there's no ATP because there's no oxygen and nutrients, then the potassium just leaks outside. Or the cells are completely dead and they've just spilt their guts outside. So that means they are leaking potassium outside. Have a look. See how we're leaking that potassium outside? Now let's zoom in a little bit here and look at some of the dying or infarct affiliated cells, right? And now let's have a look at the healthy cells that are next to it. All right, and you've got your lead here. So these cells here, they've started to leak out their potassium. So this potassium is leaking outside. Now remember one of the things I said. I said that in order for the resting membrane potential to be positive on the outside, negative on the inside, we need leaky potassium to come out, right? So these healthy cells, they've got potassium inside, and that potassium wants to leak out so that they can have a resting membrane potential. But if they're surrounded by all this potassium in the extracellular fluid, they're not going to leak that potassium out, and the potassium stays inside, making the inside more positive. Now, what did I say before? If the inside becomes more positive, it depolarizes. That's how we depolarize a cell, by making the inside more positive. So because of the dying cells here, the leaky potassium makes the surrounding cells depolarize early, at rest. So the P wave hasn't happened, so the atria haven't even depolarized. So at rest, these cells are depolarizing early. And as you can see, they're going to be depolarizing in the direction of that lead. And what that means is this: if they depolarize in the direction of the lead, the baseline, right, because nothing's happening, the baseline, remember, depolarization in the direction of the lead, you get an elevation. The baseline elevates. So if we were to stretch this baseline out, right, across here, this is the normal baseline for a heart that's not undergoing an MI. In subendocardial infarct, these cells are depolarizing early here at what we call the TP, because remember, after the T wave, you then get a PQRS complex. The whole thing occurs over and over again. The T to P segment, when nothing's happening, this is what gets elevated, right? So we've got a new isoelectric point. And then the P wave depolarize, the atria depolarize, giving us the P wave. Then the ventricles depolarize to give us QRS. But here's the thing, once everything's depolarized, there's no charge difference that we picked up earlier, right? So everything's depolarized, there's no charge difference. And then when we reset the heart, what we actually do, we're resetting the charge of the heart. So all the cells go, I'm going to release my potassium. That's how we reset the charge. And so if you're throwing all the potassium outside, there's no, again, charge difference existing. So it goes back to its normal baseline. So what we get in a subendocardial infarct is that you get what looks like an ST depression. But in actual fact, it's not an ST depression, it's a PQR elevation. It's an everything else elevation. I'll say again why. The dying cells release potassium, and the extracellular fluid is filled with potassium, and the healthy cells are less likely to let their potassium leave to have a resting membrane potential. But if the potassium stays in, they become too positive and they depolarize early. When depolarization happens in the direction of the lead, like it's happening here, the ECG trace picks that up as an elevation. But because it's not a P wave or a QRS complex, it picks it up as the isoelectric point is elevated. And then, with it elevated, you get the P wave, you get the QR and then S, and then you get the resetting of the heart that happens normally. So that is what's happening subendocardial. If you have what's happening transmural, same thing, right? Except in this time, the potassium is not exiting in the direction that it did before. It's exiting away from the lead. So the healthy cells surrounding, they depolarize early away from the lead. So in this instance, when you've got transmural, the depolarization is happening away from the lead, so the baseline goes down. So the baseline's now here. And then you have a normal atrial depolarization, and then ventricular depolarization. And then once the whole thing's depolarized, there's no electrical charge difference to pick up, because everything's depolarized. Remember, in the beginning, the baseline was different because these ones depolarized early. But once everything's depolarized, it's just like a normal ECG now. So it can go back to its normal baseline. And then that's why you have your ST segment elevated. And then the whole thing happens again. So again, it's not that you have ST elevation, which we often call it. We have everything else depression, right? So I hope that helps make sense of what's going on when somebody has a heart attack, either subendocardial or it's progressed even further and they've got transmural. Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter, and TikTok at Dr. Mike Todorovic, at DrMikeTodorovic. Speak to you soon.